Okay, so after we've completed the part of collecting anamnesis, physical examination, and after we've discussed additional findings from accessory diagnostic procedure, radiologic examinations, and laboratory data, that is, after we've collected all information and analyzed it, after we've set up the preliminary diagnosis, after we've performed differentiation with diseases which have similar symptoms and same clinical manifestation, after we've distinguished one from another, we are able to complete our final clinical diagnosis. So, as it says in the manual, for substantiation of final diagnosis, you should list the typical symptoms, signs, changes in the laboratory instrumental diagnostic method data. That's already done in previous sections. The diagnosis documents the expected course of disease, severity, complications, and so on. So, as a result, in a field of final diagnosis, we have three points. Number one, principal diagnosis. Principal diagnosis is the primary disease. It is a disease which mostly requires medical help right now. So, if we've confirmed that the patient has acute appendicitis, if this patient has positive peritoneal symptoms which manifest clinically during physical examination, and if you've confirmed signs of local peritonitis by some radiologic data, either abdominal ultrasound or by a CT scan, you may point out that this disease, acute appendicitis, is complicated because, except acute appendicitis, this patient also has localized peritonitis. What will happen if we won't do nothing? The peritonitis will develop, and if we still won't take any actions, the patient will die because of generalized sepsis. So, acute appendicitis is a disease which has maximal threat to our patient's condition right now because it is complicated by localized peritonitis, and if no actions would be taken instantly, this disease will lead to patient's death. But can this patient have some additional diseases which were revealed during our diagnostic procedure? Yes, of course, he can have certain additional diseases which are not pathogenically related with acute appendicitis, but still, as they are diseases, they might carry in some sort additional risk for patient's health, or those diseases may compromise further treatment in some sort. For example, if during chest x-ray and during physical examination of breathing system you've identified that the patient has chronic obstructive lung disease, For example, in a form of chronic obstructive bronchitis, this condition, although it's not a leading condition in patient's health right now, but it may lead this patient to postoperative complications. He may develop postoperative pneumonia, for example, after lung ventilation. And if this pneumonia won't be treated, it may get worse, and this patient may develop breathing insufficiency in future. And this in its way may also lead him to crucial consequences. So we must be aware that he has other diseases which do not carry the same threat as the leading disease, the principal disease, and we should keep that, we should reflect that in the final clinical diagnosis section. Next section to which we proceed after we've established the final diagnosis, as it is an academic case history, you must write a brief overview about etiology and pathogenesis of acute appendicitis. So let me remind you, I hope that all of you know that etiology are reasons why one or other disease occurs, what leads to developing this disease, what are the factors which provoke this disease one or another, and pathogenesis is how the disease exactly develops. Pathogenesis is a sequence of pathological shifts inside organism which occur because of etiology. So etiology, this is a cause, and this cause leads to something. It starts the malfunctioning process which becomes self-sustainable and self-developing. So other development may create another etiologies, and other etiologies may create other pathogenesis. For example, if we make a statement that the etiology of acute appendicitis in this exact patient is related to dietary factors, let us just hypothesize that acute appendicitis in this particular patient was provoked by some very specific food. It provokes acute appendicitis itself. Acute appendicitis develops the pathogenesis of inflammation. Inflammation leads to destruction of appendicular tissues. Then, if no actions are taken, in some moment those appendicular tissues may disrupt, and it will lead to the perforation of the appendix. If the perforation will occur, then the feces from the intestinal lumen will pour out inside the abdominal cavity, and that will cause peritonitis. So that's very simplified how etiology causes pathogenesis, and how in its order some pathogenetic waypoints may become etiology of something new with new pathogenesis. So I want you to write it very briefly in your case history in this section about etiology and pathogenesis. You will find all necessary information about etiology and pathogenesis in the additional literature I've shared with you. Next section, after we've described briefly the etiology and pathogenesis, are complications. In this part, you should list all complications possible in present disease and then complications found in the patient. So if you will succeed and write the section about etiology and pathogenesis correctly, then this section about complications, it won't be necessary for you. So I strongly suggest you to pay attention to this part of case history. Next, after etiology, pathogenesis, and complication, we move to the next section, course of disease. Well, in surgery, if we are writing a case history of a surgical disease, the course of disease is in certain way irrelevant, because the treatment is still the same. Treatment is surgery, because in further we're gonna talk about operations, and treatment is what makes the next section of our case history. As we are studying a subject of surgery, treatment in surgery is operative, but we have to prove that. So what you have to do specifically in a surgical case history, you have to write down briefly a passage which is called preoperative epicrisis. Here you point out the disease you're talking about, you briefly write down proofs which make you think that this is the exact disease we're having in a particular patient. Proofs or evidence of a disease are results of your anamnesis, physical examination, and diagnostic data from radiologic and laboratory findings. So in this sentence you write that according patient's complaints, physical examination data, shortly instrumental data, laboratory tests, also very briefly, we make a conclusion that this patient has acute appendicitis. And this leads us to further conclusion that future treatment strategy must be based on applying surgery. So pre-operative epicrisis, this is a passage where you justify surgical attempt. After you've done that, you proceed to the most specific part of a surgical case history, which is the operation itself. We skip the process of getting the patient into the surgical department. We skip the process of transferring him from surgical department to the operating room. We also skip the anesthesiology phase. We just mentioned the type of narcosis, and next stop where we continue our case history is surgery itself. So now we imagine that we are surgeons who are about to operate this patient, and we must describe what exactly are we going to do. All this description is called the operation protocol. This will be the next paragraph of our case history, and first thing where we start with the operation protocol, we must identify the patient once again in measures of safety. Because usually when surgeons enter the operating room, the patient is already in a state of general anesthesia. He won't be able to answer your questions, and you must be sure once again that you are about to operate exactly this patient you've examined previously. So you begin with name and age of patient. Next, you once again write down his final diagnosis. After that, you must obviously mention name of the hospital, and department. Let it be Department of Surgery. But what you have to know about operation protocol is that at this point your final diagnosis becomes also pre-operative diagnosis. It means that you never can know what will happen during surgery. You can't know exactly what will you find during abdominal exploration. You may find some additional stuff you've misdiagnosed, or you may find another disease. You can't be absolutely 100% sure about that, but if it will happen, it will change the diagnosis of this patient. But still, you begin with pre-operative diagnosis, the diagnosis with which the patient enters surgery. Next, you write down name of anesthesiologist, as narcosis has already been given. After you've mentioned exactly the name of anesthesiologist, you also must mention the type of anesthesia. It can be general or local or regional, as we've learned it in our previous classes. Uh, Appendectomy technically can be performed even under local or regional anesthesia, but in our case we decide to perform general anesthesia, so that's what you write down. Uh, you will have to mention the type of general anesthesia. Next, we move on to naming the surgical team. Surgical team consists of primary surgeon, it is the one who exactly performs the surgery itself. Primary surgeon usually has at least one assisting surgeon. Usually, primary and assisting surgeon it's enough for appendectomy, but in some cases when the operation gets complicated or the extent of operation has to be enlarged, primary surgeon can ask for help of another assisting surgeon. In that case, when the surgical team expands, assisting surgeon turns into assisting surgeon number 1, and we add assisting surgeon number 2. But we mention here that it's optional. And also we have to mention the name of the operating nurse. After we've mentioned this, we proceed to the name of the operation we are about to perform. So generally, the surgical maneuver, as we've also previously discussed in our classes, the surgical maneuver here is called appendectomy. If you use some specific operative access, not open access but some other type, you should add that in the beginning of the operation name. For example, it can be laparoscopic, or it can be robotized, it can be single port laparoscopic, but still the extent of surgery remains the same, and that is appendectomy. After that, you proceed to the most complex part of operation protocol, which is known as the description of the operation. At first, you begin the description of operation from patient's positioning on the table. Usually for appendectomy done by any access, the table position is supine. So that's what you begin with. That patient's position. Next thing what you do, you perform the aseptics and antiseptics. You do the preparation of the operative field, and this is where you describe how exactly you've performed the preparation of an operative field. So you may write down here that you've performed this preparation with some different solution. You might check it in the additional literature what are the solutions used for operative field preparation. For example, it can be betadine, or it can be chlorhexidine, or it may be, for example, even 70% alcohol. After you describe that, you must point out that you've performed surgical field dressing, in this case it means that you've surrounded the right inguinal region. It's a zone where you are about to do the incision. You've surrounded the zone with sterile drapes. After that, you proceed to skin incision. You describe the operative access you've performed. In this tutorial, we're gonna talk about conventional open appendectomy. If some of you will wish, you'll be able to describe it for laparoscopic appendectomy or robotized appendectomy. That will bring an extra bonus for you if you will do. But still, we write down that a McBurney operative access had been performed. In order to complete this access, you must transect skin, subcutaneous fat, Poneurosis of external oblique muscle of the abdomen. Then abdominal wall muscles posterior sheet of internal oblique muscle of the abdomen aponeurosis. And after that, parietal peritoneum as the last layer of anterior abdominal wall. We won't complicate the description of surgery, and we won't stop on the specific devices and instrumentation with help of which you've performed the operative access. If some of you will be interested, we'll be able to discuss that more deeply, either with via internet or in future in our live classes. But anyway, this is the description of operative access. So let's name that part. Next, after we've entered